Welcome back to the Positive Veterinary Dentistry podcast, where we explore the art and science of veterinary dentistry and oral surgery through conversations with the experts shaping our field. I'm your host, Benita Altier, licensed veterinary technician specialist in dentistry, and the founder of Positive Dental Education. Today's episode is one I've been excited about because we're diving into a topic that combines precision surgery, early intervention, and truly life-changing outcomes: cleft palate repair in puppies. But what makes this conversation especially important is that many of these cases are first seen in a general practice setting. So today we're going to focus on not just the surgery, but how you in a general practice recognize, manage, and advocate for these patients early. Joining me today is Dr. Kendall Taney. Dr. Taney is a diplomate of the American Veterinary Dental College and an AVDC fellow in oral maxillofacial surgery. She is the owner of the Center for Veterinary Dentistry and Oral Surgery in Gaithersburg, Maryland. She attended Virginia Tech and completed both general and surgical internships prior to her dental residency. Her special interests include maxillofacial reconstruction, oncologic surgery, and palate surgery, making her one of the leading experts in managing complex oral defects like cleft palates in puppies. Dr. Taney, welcome to the show.
Hi, Benita. Thanks for having me.
Yeah, absolutely. We haven't really had a lot of history together, Dr. Taney. I know of you. I have seen you. I have sat in on your lectures and listened to your wisdom over the years at the Veterinary Dental Forum, but that's where our paths have crossed. However, we do have many friends in common, and I really appreciate Dr. Naomi Hoyer, who is a friend of yours, tag teaming you to be on my podcast today because this topic is very relevant, and I know you have so much incredible wisdom to help our DVMs out there and our teams learn a little bit more about what to see in these puppies to really call us to action to do something about this. So Thank you again.
Absolutely.
Before we dive into today's topic, my last guest left you a question. And this question is coming from Dr. Stephanie Goldschmidt, which I'm pretty sure you know her.
I sure do.
The group of oral maxillofacial surgeons is really small in the world. So you guys have definitely had a lot of, I'm sure, time together to really talk about the struggles of getting through a process like that.
Yes.
So Dr. Stephanie's question to you is, what is your favorite animal that you've ever treated? So you could let us know like the kind of animal, maybe even a specific thing about that particular case that kind of stood out.
Oh my goodness. Favorite kind of animal.
Or your favorite animal.
Or my favorite animal. Oh goodness. Wow. I'm trying to think of one in particular.
There's so many.
There's just so many very heartwarming cases that we've had over the years. I can think of one in particular. He was this older beagle and sweetest dog, but was referred, he had major exophthalmos, and everyone was convinced this dog had a tumor. And a lot of those dogs don't even make it to me because they've already been told there's not a lot of hope, that the people really wanted to try anything they could to save their beloved pet. But it actually turned out that this dog had a zygomatic mucocele, and so it was not a tumor at all. Dramatic before and after photos on the same day of this dog with this really huge painful eye. We did a resection of the zygomatic salivary gland, and he was back to normal. And it was like everyone had sentenced this dog to die, essentially, or expected that there was no good outcome there. And my intention at the time was at least to give the owners some peace of mind. Hey, you've done everything you could. Maybe this is a tumor, but it turned out to be something very fixable. That's just one example of, I think, my everyday life in dentistry, which is why I love it so much.
Absolutely. And what a great answer for Stephanie's question, because her topic was oral tumors in dogs. And just talking about how important it is that we actually do the workups in the beginning properly before we give the client, like you said, information that could lead to a decision that could be devastating for the family, for the pet, and not necessarily jumping to conclusions based on just your first visual look at the patient. And then thinking doomsday has set in, right? You can see that the happy day, this dog was feeling so much better. And then just same with the surgical skills to be able to deal with the face can be really tricky. So we're going to talk a little bit more about oral maxillofacial surgeons like yourself and why this type of referral is out there and what kind of things that you do. So we'll shift into today's topic. This is one of those conditions where early recognition can completely change the outcome for the patient. We're going to talk about specifically puppies and abnormalities when it comes to their palate or lip or whatever it is that seems to be what you're seeing and what you're having to address. So I'm sure there's a lot of this that I don't even really understand or know about, and I would love to learn more from you today. Sure. And we're talking a lot to general practices and the DVMs there that may not have as much experience with this. What do you think when you are examining a puppy, the most common signs that we might be missing on a routine puppy exam that could lead us to the realization that something needs to be addressed surgically or medically as well? But we're talking probably more surgery here, I would suppose.
Honestly, actually, a lot of people are alerted pretty soon after these guys are born because they're not thriving and most of them, they're having difficulty nursing or milk is coming out of their nose. There can be some, in the case of the cleft lips, there can be obviously some clear deformities, but if it's not super obvious right away, but this puppy is not gaining weight or coughing, again, nasal discharge, then an oral exam at that point may show a secondary cleft defect along the roof of the mouth. So I do think it becomes obvious pretty quickly. There may be puppies that are maybe never even get looked at. They just assume, oh, this puppy is not thriving and fades away, which is sad. But I will say the toughest thing I think about these cases is it really does require somebody to be very dedicated to raising them. And so as a veterinarian who might be the first person to counsel someone, if this is a breeder, the breeder may say, this isn't something that I can do. I can't raise this puppy to the point. They can't have surgery when they're 3 days old. I mean, that's the issue with the cleft defects is we need to wait until they're generally at least 4 months of age. Usually we know well before that there's a problem. Unfortunately, some of those puppies may die early, kittens too, or it's just a matter of we don't have someone that can really dedicate the time to tube feed them. That's one of the ways that they have to be raised because they can't nurse normally. At least getting them to the point where they might be able to eat on their own and not necessarily nurse. There's some amazing Facebook groups out there about raising puppies like this. But again, it requires someone who's like, I'm committed to raising this particular animal. They become extremely attached to them. They want the best for them. I'm always just so impressed. People thank me for the surgery, but I'm like, I'm impressed at what you've done to get this puppy or kitten to the point where we can even do surgery. So I think there needs to be empathy on either side because not everyone can do that, or there may be setbacks along the way that they are getting upper respiratory or aspiration pneumonia, and if their quality of life is not good, we as veterinarians have to be able to say, hey, there may be a point where we say it's okay to let an animal go because we're not really able to provide them with a good quality of life. But if we can, again, get them past that point, as I said, the Facebook groups are really good about recipes for creating gelatin food, like cubes of dog food or cat food that they can eat that don't necessarily get caught in the cleft. They get their moisture that way. They get hydration that way instead of drinking water because they can have issues with that as well. I think it is, like I said, it's being supportive to those people that are putting so much time and dedication into raising them to the point where they can actually have surgery. So sometimes I do see them earlier on, but I usually tell people like I don't even start planning the surgery in my head until I'm at a point where I'm like, I'm almost ready to do surgery because everything can change dramatically. A cleft can look massive, and that may be one thing that is sad with these cases, that someone may look at them when they're 2, 3, 4 days old and be like, there's no way this cleft, it's so huge, it's like the whole roof of their mouth, or we're never going to be able to fix this. But as that puppy grows and matures, it actually may narrow down pretty significantly. I think if we can, again, I know that we can't save every single one, but if we can get them to that point where we have allowed them to mature, that sweet spot of 4 to 8 months of age is what some of the more current research has shown. that not earlier than 4 months, but hopefully not too much later too, the best success. So like my sweet spot is more like 6 months of age, just because sometimes also these puppies and kittens are usually pretty small. So because they're not able to get a lot of nutrition in. So I do have a really fun story about one that I did recently. I think just going back to this whole dedication, and I know that this person would not mind me talking about her in general, but she's a Maine Coon breeder, and I had on my schedule. I knew they had called and said, when can we bring him in? When can he have surgery? And I saw them as a consultation, and this kitten was tiny. We're talking a Maine Coon that was like, I don't know if he was even 3 pounds and 2-3 pounds, so tiny. But they had just committed to raising this guy. And I said, okay, the soonest that we can do surgery is 4 months. And so from now until then, do everything you can to get more weight on him. Like the closer he is to 5 pounds for me, the better I'll feel. And again, just was so impressed with like all that they would do to get him to the point where he came to see me. He was still very tiny, very small. But we did end up doing surgery at 4 months because he was really having a hard time. He's eating the gelatin, but I think he had a secondary cleft, hard and soft palate. So it was like the whole thing. And I always have to tell people too, this is the thing about any kind of palate surgery, is that it's not always successful on the first try. I think your best chance of success is on the first try. So we always absolutely aim to do our best and hope that everything closes. But I tell people, like, not only have you done all this work and dedicated into raising this puppy or kitten, but I can't guarantee the outcome of the surgery. So with such a long, extensive defect in such a tiny mouth, I was a little concerned that maybe it wouldn't all heal. And he did have 2 areas of dehiscence, one in his soft palate and one more mesially. Not a big surprise. But then we thought he had healed enough, but he was having upper respiratory signs, and she was like, oh, he's not really eating well. And it became this entire saga of, okay, I just was like, bring him in, let me look at it. I'm going to sedate him, and I'm going to put a feeding tube in because he's so little. He can't possibly keep going if he's not able to eat, when he doesn't want to eat on his own, and you're not able to necessarily tube him anymore. So that turned into, he actually had FIP. And the way that we figured that out was when I took my x-ray to check where my tube placement was, I was like, oh my God. I thought he had aspiration pneumonia just from the time that he had these 2 not very large areas of dehiscence. So I was shocked. And actually we were emailing back and forth, and she was like, he's making a funny noise. I'm worried about the tube. And I said, you know what? I'm going to send these x-rays out and have a radiologist read them. And the radiologist was like, this is not aspiration pneumonia. This cat has probably something like more concerning with pleural effusion. And yes, he had FIP. And again, this person being as dedicated as she is to this kitten, she actually got him through with the treatment, which I know nothing about these treatments that you can do for FIP, but these newer drugs, and got him through this really critical period where we really were so concerned like he wasn't going to survive. To the point where he recovered from that. And then I did my second surgery, fixed the 2 holes, and now he's like living his best little Maine Coon life. And I think the 2 of us were just like, she said to me, like, I think it was a miracle that you said you would see him and put the feeding tube in, and then you took the chest x-ray and you were like, oh crap. And then you sent him out, and then it was just like this kind of sequence of events that I think were all little miracles that got him to the point. Because we might have assumed, oh, this poor kitten, he aspirated. Oh, we did everything we could. But and she would say, thank you, you've saved his life. And I'm like, I did some surgery that I like to do, but you have spent months getting this kitten to where he is. So I know that is one of my, by far, favorites.
Well, that's a really amazing story, and all the stars had to align. So she brought the cat to you at the right time, and then, just all the things that happened just led to the favorable outcome that you guys got to eventually. But oh, that kitty is a lucky kitty. He might have used up a couple of his 9 lives. But one thing I'm taking away from what you have said so far is that it's really important that a general practitioner finds the breeder population in amongst their clientele and really tries to reach out to help them into the fold, into the team here. Because I know from my experience working in small animal practices over all these years, sometimes we get a little bit in this back and forth tug with some of the breeders because they don't necessarily want to reach out to us to get advice. They often reach out to other breeders or the internet or Dr. Google or wherever they're reaching out. But if we're to be successful, we really have to work together. And if they are trying to have a responsible breeding program and they have these particular breeds that are prone to this, or this could just happen to any puppy or kitten in general, if they don't recognize it early, because they might have a whole litter of puppies or several kittens, and they don't really realize that one of them's not doing that well until it potentially is too late for that animal. And that then if we as general practitioners can really understand what the next steps are or what we should be looking for, or that maybe we should have them come in for some sort of exam on the newborns, the neonates, instead of waiting until they're in their new homes and then they finally get to a vet. So what do you recommend in regards to that with your breeder clientele or from your referral veterinarians, and they have these people in their clientele that are breeding dogs or cats, as far as having those new kitten or puppy exams on the neonates before they're ever weaned?
Yeah, for sure. I think obviously, especially if it becomes clear in the first couple of days that there's one that's having a problem, not just focusing on the one. Let's make sure that there's not some other congenital issues with the other puppies or kittens in the litter. And if that is identified, that breeder, like I said, not maybe doesn't have the ability to invest the time and the resources into raising one of those, but there might be someone on staff who's, I've raised this type of puppy before, or hey, there's this Facebook group, at least look into it, reach out. Yes, and then some of the clefts can be fairly minor too, like especially the lips. A lot of times the lips look really dramatic, the primary cleft palate, but they're almost, some of them are just simply cosmetic. Like in a person, obviously we would need to fix those for people's speech and ability to have social confidence and things like that. But we've all seen lentil and like some of the puppies that are out there on social media, dogs that they're so cute. I think they're so cute with their little lips. I've seen some of those cases where I've even said to people like, look, we've investigated it. We've at least done the diagnostics and everything, but this is really primarily cosmetic. It's up to you. Like we can certainly fix it, but if it's not really causing them any issues, then great, it's not clinical. So even some of the secondary clefts can be so narrow that they're not having a lot of clinical signs, or if your initial repair doesn't work, they may have such a small defect that it's just, again, not affecting them clinically, which we would consider to be successful. So yeah, it is definitely early intervention. It is connecting people with the right resources. There may be breeders that perhaps just don't know what options there are or have the thought of tube feeding, and they may not know the gelatin idea, which I thought was genius. There's just a lot of newer things that we're learning that we gain from other people's experience, even like temporary obturators. So just getting puppies through a phase where there might be something that's made, like a custom made obturator. That I have not done those in myself, but there's some articles about that. Actually, research was done about clefts and why they develop, and I think it was, I forget the type of breed, I don't know if it was Springer Spaniels or what, but that whole paper was making these little obturators, and then every couple of weeks they'd have to make new ones because the puppy would have grown, but it can maybe get them to the point where, I think that's where we have all this new exciting technology in terms of like 3D printing, that we can maybe come up with some new fun ways to just get them to the point where they can have the definitive and final surgery. So I think that's an exciting area.
With cone beam CT, is this something that you're doing prior to a surgery like this? Is this complicated enough that you would actually not only perform the cone beam CT, but do some sort of 3D printing to plan your surgical approach for some of these 4 to 6 month old, eight
Right.
month old puppies or kittens.
Yeah, I think for sure that like the cone beam is a absolute must because the defect itself the soft tissue portion of it is like the tip of the iceberg. It's almost you need to know like what bone is underneath there if there's any. There can be situations where there's just no the shelf of the palatine shelf of the maxillary bone is non-existent or the farther back palatine bones are not present. So if you don't have bony support underneath your repair, it tends to be more likely to fail. Which you almost never do, but that might influence your decision. There's been some papers out of Penn where they use the ossiflex bone membranes to try to almost like bridge that area, just mostly to provide support to the flaps themselves as they heal. So I personally don't think that you can or should be doing this type of surgery without a cone beam CT because you're just going to miss so many things because this is a congenital problem. They're going to have other congenital issues. Again, numbers of papers on bulldogs and brachycephalics, and not only do they have a cleft, but they have abnormal tympanic bullae and just all sorts of aberrant sinuses. And that's very important not only for the surgery, but for the owner to understand because you can actually have a perfectly healed cleft repair, but their sinus cavities are not normal. Like they're never going to be normal. They didn't develop normally. You have to prepare the clients as well that, hey, we're going to do the surgery. Hopefully this makes things so much better in terms of food and water going in there, but your dog may have nasal congestion its entire life. It may have nasal discharge its entire life because it doesn't have normal functioning turbinates and sinuses just based on how they developed. So yeah, I think it's super important. I think printing I haven't done so much of for this type of surgery because it's mostly soft tissue, and with the cone beam at least it's really just looking at the bone and I'm not really moving any bone around, but absolutely not wrong to do, and maybe others are doing that. And then doing the CT as a planning cone beam CT before you even do surgery, certainly not wrong. I've done both. I guess I tend to do all in one kind of scenarios usually the same day. I'll do the CT and then do the surgery right then and there. Come up with a plan and at least do something that initial day.
Yeah.
So
with these patients having other potential congenital abnormalities and with the uprising of the Frenchie as being the number one favorite dog, I guess, in the United States anyways, I don't know, maybe it's also ranked in the world at that high of a level.
Yeah.
We're seeing more and more of these animals that are brachycephalic. Is this truly one of the conditions that is overrepresented in brachycephalic dogs?
For sure. I think so. It can happen in any breed, but I do think I'd have to go back and look at the numbers, but they're overrepresented by far, I think. I mean, I would say just for whatever reason, that's absolutely going to be, that's what comes to mind when I think about my weird things on cone beam CT. Pugs don't have frontal sinuses. And then I grew up with brachycephalics. So I've always had a bulldog. I've always had something smushy. And I had a Frenchie who passed away at the end of last year. And he went through every Frenchie thing possible. Airway surgery, back surgery, allergies, and you know, as much as I love the breeds, I know that's a question, a controversy that comes up a lot is, what are we doing here? What are we doing to these dogs? It's tough. I understand the draw because their personalities are just wonderful, but I don't know that I'll ever own another one based on how much I went through with my last one because it was so heartbreaking in the end because he just was not living a good quality of life.
Yeah. It's good that you were his mom because you did everything, I'm sure, that was humanly possible to make your dog comfortable and had a good life. So
yeah, I mean,
that's tough.
I think as animal lovers, I think we all feel that way. And especially us working in the field like we do, that's what we're here for. And I think they bring so much to our lives, and we need to be able to do everything we can to give back to them and
for sure.
not consider them to be throwaway things.
And you mentioned that there might be someone on staff that would take in that puppy and do the tube feeding and everything. And as technicians, we've all taken in our fair share of these little orphans. They're not exactly orphans, but they have to be taken care of intensely. And it should never be underestimated, the willing of many veterinary professional in a hospital to just go ahead and take on a little one like this, because it's temporary. We hope to get them to a place where they could have surgery, and then hopefully they can go on from there.
Yes.
So you mentioned that you like to wait until they're at least 4 months of age to consider doing the surgery. And I did hear you talk about the fact that we need to let them grow and see what their bones are going to do. Are there any other specific risks or anything that we're waiting for physiologically to happen besides what you mentioned in regards to the timing of these surgeries that one of our GP vets might want to know about?
Yeah, I think the 4 month mark is, like I said, mainly trying to get a lot of them are going to be very small and underweight, trying to get them to a point in their life where maybe they've gained enough weight that they can go through an invasive procedure, but also the growth of their skull is rapidly occurring during that time frame. So trying to do it beforehand, it's almost like the tissues just pull themselves apart. So that's the big reason for the 4 month mark. And then there's never a point where I would say, oh, this dog's 2 and no one ever knew it had this defect, we can't fix it. And again, that's based off of some papers that and off the top of my head, I'm not exactly sure why we find that this 4 to 8 month range is the sweet spot. But I think also it is getting it done as soon as possible, because we know the animal's having a hard time eating, drinking, and all that. So the sooner we can do surgery to avoid repeated bouts of aspiration pneumonia, obviously that's everybody would love for the pet to be able to eat and drink on its own without issue. But I think the main thing is just they're, like I said, too small, or that the surgery itself isn't likely to be successful. So me personally, I haven't ever really done anything younger than, I've been right on the edge of 4 months, and like that little kitten, I was like, oh, I wish you were a little bigger and a little older, but you're not.
Yeah.
And
in cats, are Maine Coons common to have this problem, but is that a breed that is represented in that way as well?
I don't know that I would say, honestly, like I'm seeing a lot more puppies than kittens in most cases.
Sure.
So he may be the only, off the top of my head, Maine Coon that I've seen, but I've seen like a bunch of domestic short hairs that can randomly have it. So
Exactly.
I guess I don't know much. Haven't seen much in the literature about specific cat breeds, but with any of the purebreds, I think we know that there's some genetic predispositions that can be propagated along the lines. And this breeder that I was talking about, excellent breeder, super responsible breeder, being very aware that we neutered him at that one point, because we're like, no, we're not going to be breeding. He's sweet as he can be, but we won't be breeding him. She was absolutely ready. That's what we did when I think we did the second repair. We removed his friends. I guess we don't see as many cats. In addition to the clefts, we get a lot of just palate defects from trauma or post-surgery. If you're doing tumor removals, not everything always heals the way you would like. So that's what my paper was about. Actually, we were doing acquired defects, basically.
And it's always advisable to counsel the clients in regards to the fact that this is congenital and that should not be passed along their breeding lines. So we want to make sure that these kind of like consultations also include, we have to talk seriously about this, because we don't want anyone else to be affected moving on down the line through your breeding program, trying to isolate how we can put that to a stop, hopefully, with that particular line, which I know some breeders don't like to hear that, you know, because they have a favorite dog, or they've earned a championships, or, you know, different things, and they don't want to take them out of their breeding program. But to be responsible as veterinarians, we have to make sure that we do our part to talk to them about these things. Now, because you're a dentist as well, do a lot of these animals also go on to have problems with tooth eruption or abnormal tooth formations or jaw development and things like that. Maybe walk us through a little bit of what you've seen in regards to those things, because we're talking about anesthetizing at 4 months, potentially
Right.
at the earliest.
Yes.
Obviously, they're still, if not in mixed dentition, they're not even having their permanent dentition fully erupted. So what kind of things can go wrong, or what goes right, and what have you seen?
That's a really good point, because that's the other reason why I prefer being closer to that 6 month mark, because at least now, hopefully, in the areas that we tend to see that tend to be in my way, be the incisors and the canines of a cleft repair. So I want to know like where, and there can be going in all different directions. So a lot of times the incisive bone is not attached. It's almost like a free floating island. There can be teeth growing into the cleft on either side. So a lot of times we end up doing selective extractions, especially if I think that's going to be a problem. I'm really pushing people to wait if we can, because then I don't have to go, oh, now I got to come back. Maybe I took the baby teeth out, but or they weren't there, but now I know the permanent ones are going to come in the middle of my surgery site. That wouldn't be ideal. And it can make it very difficult for you to close defects in that rostral portion around the like incisive papilla. The incisive papilla, and so that little mound of tissue right behind the incisors on the roof of the mouth, or the junction of the hard palate and the soft palate, are the two most common areas of failure for cleft repair. And a lot of that is, like I said, because that incisive bone, either it could be unilateral, it can be bilateral, but it's not attached to the maxillary bone. And there's this big defect or cleft into that area that you need to elevate up. But if you have teeth in your way, you're never going to get that tissue to close. I've had to, most people are pretty fine with whatever I say needs to be done. I've had a client or a couple clients that are like, oh, you have to take those teeth out. And I'm like, do you want the teeth, or do you want the not to be a hole? Get it? Like, I want to save teeth too, but I would prefer to do one and done surgery. That's always my goal. So if I know I can get the best chance by doing selective extractions, or in the case of absolutely super common for other malocclusions, so skeletal malocclusions, brachignathism, any of those, I've just done this beautiful repair, but now my mandibular canines are going to be jamming their way right up into that. That's a problem. So it's definitely getting that whole picture of how this dog's or cat's jaw functions. What is the occlusion? What other things can we do to ensure the success of the repair right off the bat? And again, I tell people, like, my goal for your pet is a functional and comfortable mouth. That's all I care about. I don't really care about cosmetics. It's why I don't do a lot of orthodontics. It's the same kind of conversation. A lot of the people that want orthodontics might want a breeder show the dog. And I'm like, that really is false advertising. We want to do it because your dog needs a perfect bite. We want your dog to have a comfortable, functional bite. So the people that are like, oh, you'll just do braces. I'm like, okay, well, yes, we can. It might be they love their dog. They're not going to breed or show. It's already neutered, whatever. But then when I explain to them, I can get your dog to function and comfort in one step, like maybe doing selective extractions or crown reductions, or you can come see me every 2 to 3 weeks and I'll anesthetize your dog for the next, 6 to 8 weeks, and you'll spend 5 times as much. Most people are like, oh no, I'm fine with just whatever it needs to make my dog comfortable.
Exactly.
So that's just been my philosophy with the cleft repairs, or with anything else, is I tell people too, dentistry doesn't always have the best like business plan, because sometimes I take all of your teeth out and I know I'm never going to see you again. But
or it can be the gift that keeps on giving.
Exactly. No, I know
that get to see them a lot in their life.
Yeah. No, I joke about that, but I'm thrilled when I know that like I've eliminated pain or discomfort. That's always a thrill.
This surgery and this problem is not for the faint of heart. I definitely understand what you're saying about the fact that we're going through a tricky time period here, where the puppy or kitten has been dealing with just baby teeth and growth, and then now we're losing baby teeth and getting adult teeth in, and the bones are growing and changing, and here we are intervening at a specific time to hopefully get them so they can eat without having all the trouble that the palate defect is causing. However, we're still dealing with a patient that's growing and adult teeth that are still partially or not erupted, and trying to imagine when to time the surgery and to avoid having to do more than one surgery sounds definitely like it should be left up to the experts like yourself in a lot of ways, because I could see where things could really go wrong if we didn't do that exactly as the best plans.
Yeah. And I think that's another important point in terms of, as a general practitioner, you might have the best intentions in wanting to help someone and maybe say this person doesn't have a lot of money, maybe I can do this, but it is a complex procedure. It's not always as straightforward as it looks. And so sometimes I do get cases that have had surgery before I get to them. And it's so I've already had two strikes against I have a three surgery rule. So I usually tell people if I can't fix it in 3 tries, it's very unlikely or less likely that we can get it to heal. So if I already am getting it on the 3rd strike, which again certainly does happen, it's just it's a bummer because the tissues have been moved around, blood supply has been affected, and scar tissue is set in. That's why, again, that first try is always your best chance at getting a repair. So I just would say, when you think you might be saving someone money, in the end, if they have to come to me anyway, and now they're on their 3rd surgery, and it's now we've spent more money than we would have if we had just gone and said, you know what, maybe this is out of what I should be doing, and just think, I understand. Of course, I'm not I don't want to be insensitive to the financial part of it, because that's a very real thing that we're all experiencing. But I think if we can have a best chance of doing it right on the first try, it's worth the extra expense then, versus prolonging that animal's discomfort and maybe spending a lot of money treating them symptomatically for aspiration or this or that, or pain and discomfort, like I said. So just, I think another way that we can counsel our clients is that understanding that it can be scary to consider going to see a specialist, but that ultimately that's what we're here for. We don't want to prolong the pet's pain and suffering at all. We want to bring our expertise and all the training and things that we've learned from the people before us to benefit the patient.
Yeah.
From the get-go.
I think that's important because we are very sensitive about the cost to the clients. However, we need to give them what the best option is and then let them consult with someone like yourself and decide. And the idea as well that you mentioned about the importance of cone beam CT, if we don't have that imaging modality in our general practice setting, and this isn't a surgery that we're really trained and skilled and we do these with some frequency, it's important that the client realizes that, because I think some clients think, you're a veterinarian, can't you do everything? Because traditionally that's right. The old school veterinary medicine, because there was no specialist, there was nobody to turn to, and so the veterinarians would tackle whatever type of surgery was put in front of them, right. And with the understanding that they've never maybe done this before and it might not turn out that well. But client expectations are very different these days. And yes. With human medicine's really progression into very small specialties, subsegments, I think as a human, we would never go to our regular dentist to have anything near this done. So, exactly. And then we're dealing with very young patients with immature immune systems and potentially other complications from the fact that they haven't been able to get good nutrition really their whole entire right. lives. And we've been limping them along, trying to get them mature enough that we feel like the time is right for surgery. When it comes to post-op care after the surgery is done by someone maybe like you who really knows what they're doing and is going to do the best that we can for that patient, ideally in one surgery, is there anything specific that you would tell a general practitioner that they should be aware of? Because maybe they're going to be doing the follow-up consults with this client. Maybe they can't travel right. 4 hours to come see you again for the follow-ups. We do have video conferences, which can make things better. But anything specific that you'd like to tell us about the post-op care?
Yeah, for sure. It's like protecting the mouth. I don't routinely put feeding tubes in every patient. I did in that one case. In fact, I almost never do. But because they're puppies, like they're going to try to find something to chew on. If I have a feeding tube, it's not just the eating part of it. It's, hey, we can't right. be letting them going and chewing toys, and you're going to need to be taking them on lots and lots of walks, doing things to distract them because they're not always the best about understanding, hey, maybe I shouldn't chew on this. But definitely soft food for 2 weeks minimum. Usually I might do it longer. So I will usually, if they can come back to see me, I like to see them back usually 3 to 4 weeks afterwards, as long as they haven't been having any issues. But I do tell clients and their veterinarians that if there's going to be dehiscence, it's usually going to happen 7 to 10 days after the initial surgery. So if they're doing great and we have allowed them to eat, and then all this is basically what happened with the little kitten, was doing great, and then around that time frame, I was like, oh, if he's had partial dehiscence, this is the time. This is right around the time. So he's back to sneezing again. He's back to this, and so now I say, well, like if they were eating 4 days ago, great, and now they go to drink water and they're sneezing stuff out, that would be where I would be concerned that we could have had some dehiscence. But this is the point where we don't panic. Okay, so the tendency could be like, we got to go in tomorrow and do surgery and try to fix this. That would be a huge mistake. So it is a setback, but we need to really wait and be patient. So if I have a dehiscence at that point, I'm not going to recommend surgery for 3 to 4 weeks, because what I want to happen is for everything to declare. So I know, what is going to live at this point, and the blood supply has been well reestablished. At that point, you can actually have greater success at your second try, or a lot of times your second try is successful because you do have neovascularization, all the vessels have come back in, and now you have good blood supply when you go in. You do initially, the surgery itself can disrupt that. So hopefully if you've gotten things to at least maybe decrease the size of the defect. But again, being patient in any surgery with oral surgery. I think that's a tendency that the veterinarian, general practitioners I get calls about. I did the surgery 7 days ago. It's completely falling apart. I'm panicking. Like don't I need to anesthetize this dog to bride? I was like, please do not. Don't do that. Just wait. As long as keep the pet comfortable. Antibiotics in this situation, we would likely recommend flushing. And almost all those cases in those scenarios will go on to heal. Delayed primary, secondary intention, just with time. It may take longer. But that's what I want with these surgeries. Again, if I have to do a second surgery, I'm trying to give myself every possible opportunity for that to be successful. So please don't go back in and try to fix it. But be aware that's the time frame of the danger zone, doing everything you can to keep them from chewing hard objects. That's really what it is. We used to sometimes try to bury all of our knots, so that they didn't have any exposed knots at all. In people, that's actually a big problem with children that have surgery, because our tongues are very flexible, and we can really work and kids will especially just work at those stitches in their mouth. But fortunately for our pets, they can't really direct their tongue at like a specific spot. So they can't really lick sutures out. They might lick more. But I know that everybody has their different ways of doing surgery. But we tried that for a little while. We try to, again, just do the surgery in a way that we don't violate surgical principles. We have very delicate and intentional tissue handling, preservation of blood supply, and no tension. Your best that you can. It's easier said than done in the mouth when we don't have a lot of tissue to work with to begin with. And so then that goes back to the surgery itself. Usually we'll start with the most simplest technique that's going to disrupt the least amount of tissue and save the little crazier transposition flaps and things like that for later. We just try to keep it simple initially and then hope that everything heals without any problem at all. It's the funny thing about these surgeries is that you can have them look absolutely gorgeous and you're like, there's no way this is ever going to fail, and then it fails. And then you can have other ones you're like, this tissue looks a little purple, I'm worried, I'm not so sure this blood supply is great, and then it just heals fine. It's this mystery.
Yeah.
So I think that all of our owners that have gone through all this and their veterinarians that support them are going to do everything they can to make that surgery be successful. So they want to follow the directions. We always send our discharge instructions to their veterinarians so that they are aware. Here's what we've recommended. Here's what their plan of action should be. Pain control as well, just to keep them from wanting to, especially if it's something external. Elizabethan collars for the cleft lips and those kinds of external surgeries would be another post-operative thing to do.
Okay. How many times would you say they need to be followed up? Would it just be that one, maybe 10 to 14 days out? Or is it something that you'd still want to see them back, especially if they're still growing or their adult teeth are still erupting?
I like to do a second sedated exam because they're usually young dogs. They don't want to sit still. Like you can do an oral evaluation, but if it was a soft palate defect, you're never going to really see back there to know that it closed. If they haven't had any issues, sometimes I'll do that at that 3 to 4 week period. There's times, like I said, where I'm like, I know there's an issue. I want to see what it looks like at least, and I might briefly sedate them or at least have them come in and let me look at it. But again, like a lot of these chondrodystrophic breeds are the ones that have squishy faces, very deep rugae on the palate. So you can't always tell, is that normal? Is that going down because it's just a rugae, or is it going down because the cleft has epithelialized again? So I do like to sedate them just to actually probe and make sure that it's all good. So I don't do that. I don't do multiple sedated rechecks, but if I can at least do one around that 4 week mark, I would be pretty well. If it's healed at that point, my expectation is it would not dehiss at that point.
We talked about spaying or neutering, and I know you mentioned with the little Maine Coon that at one of his anesthetic events, it was time to go ahead and do the neutering. Do you recommend any specific timing as far as like when they should go ahead and do a more serious thing like an abdominal incision, spay, surgery versus dealing with the mouth? How would the general practitioner explain the timing of all these things? Because we don't want them to pass this on genetically. We do want to recommend that the patient is altered. And we do know that sometimes that hormonally, like there's delaying of spays these days, which it's all the timing of everything and not anesthetizing them so many times, even though they're young. And this is a time if we're going to have to anesthetize that, you know, it's hopefully going to be the risks are minimized because they are very young and they have good, strong organ function and things like that. But what would you tell a general practitioner in regards to timing of all that?
Yeah. So for me, if someone says I can neuter their pet, it like makes my entire day because I love to neuter anything, but I don't enter body cavities. So unfortunately, I've had people ask me, can I spay? And I say, no, I'm in dental practice. I'm not going to go into your abdomen. Not happening. So yeah, I don't, in that world, like I actually have a new puppy. This is the ridiculous portrait of my puppy that I did not realize was going to be as huge as it was, but
that's adorable.
It's massive. My narcissistic dog. No, just kidding. She's 6 months old, and I'm like, we always just spayed our pets like at that age
before the first heat cycle.
Yeah,
right?
And so, and now I'm like, oh my God, there's all this new stuff out there, and it's so confusing. And I don't think even we have come up with any consensus. Breeds. I guess I don't really know how to answer that. I think I was happy to do it in that case with that. I've done it. I've neutered tons of pets in this scenario where we're doing something for occlusion or clefts, or they're around that age where people are ready for them to be neutered anyway. Let's be honest. I guess I can't think of how many giant breed clefts I've done where I'd say maybe don't neuter them because of orthopedic issues. That would be a consideration, mostly because health-wise, even though these dogs may not be real normal in a lot of ways, not just the mouth, but other ways, we still want to try to allow their bodies to grow as they should. So, yeah, like I said, the kittens and the puppies, like the mixed breed dogs, like if somebody wants me to neuter them, I will do it. And I think it is nice that, especially if we're going to have to just do additional anesthesia and we can avoid another episode, then I do get that request a fair bit.
Okay.
For neutering.
Yeah, there's not too many veterinary dentists that I know that will approach anything but dentistry or in your case, oral maxillofacial surgery. Is there ever a time that surgery is just not indicated with these little guys?
Yeah, I think, like I said, the primary clefts where it's the lip and it's mostly cosmetic, they don't always need surgery. And again, that point I made where not making a decision about what size the cleft is going to be until you're close to doing surgery, because you can have one that's triangularly shaped, diamond shaped. There's a whole paper about the different shapes that they tend to have. And the wider they are, the more difficult they are to close. So I've seen them be so narrow that the people really feel like the pet is not clinical. You know, they're not getting, the food can't actually get up in there, but water might occasionally creep in there and they might sneeze. But Or we might have done a repair and there still is a tiny little defect, but the clients are like, he's not showing any signs, he's not, having nasal discharge, and so they're happy. So we would say that's functionally closed, even if it's not completely closed. So I do think there's scenarios where the cleft is narrow enough that if they're on like a kibble, especially, the larger pieces of kibble can actually get into the cleft. There's some animals that live with clefts that are huge and people say they don't have symptoms, and I'm like shocked. Like I've had one that was so huge that the theory was like nothing can even stay up there. It just falls back in. So gravity. It's like nothing is getting stuck in anything because it's just so wide.
Wow.
So
I did one of these episodes with Dr. Chris Bannon, and when she was asked what was the most unusual thing that she found inside a patient's mouth that did not belong there, her example was a baggie, like a Ziploc baggie full of blueberries that was up in a cleft palate.
Oh my gosh, that's crazy.
I guess the blueberries went missing and they found them with the dog anesthetized. So I was like, that's a good one. I've never found blueberries in a Ziploc baggie in a cleft palate, but
no,
don't put it past them. They'll whatever can go up there will.
Yes, that's true.
Yeah. And just kind of about this too, I was thinking you've learned so much over time. Is there anything that really has changed your approach to these particular surgeries based on an experience you had or some emerging technique?
And I think the biggest thing for me is the acronym that I guess applies to all surgeries of keep it simple, surgeon, or another S word, but is that I trained with Mark and we both really liked the palate surgery. So we'd be like, oh, let's try this flap. Let's do this. We would do a lot of different types of transposition flaps or fold over flaps, and they work great, obviously, when they work, but they can take away a lot of tissue on that first try. So now I feel like I've transitioned to be like, okay, what's the simplest thing I can do to close this on this try that I think is going to work without getting fancy just because I can. And then, again, in the interest of tissue preservation. So I think that I've gotten to a lot of what we call the von Langenbach, which is really just moving the tissue into the midline. And I would say we didn't do that nearly as much as I do now with these cases. And I think it is, if that fails, it's almost like you've done nothing. You might get some healing, but you haven't really wrecked any of your hard palate mucoperiosteum. So then you can do something more advanced at that point. Of all the great papers that have come out, like Alex Reiter and all these different techniques, his little vest over pants technique and all these different ones that have been written up, we've tried them all because we're like, cool, let's try, that's a cool technique, let's try that. So yeah, I think keeping it simple.
Okay.
That's what I'm trying to do in my whole life, everywhere.
I know, because sometimes we can make it too complicated, but I bet there's also something to the fact that if you get a technique that you feel is not only simple, efficient, effective, and you do that technique over and over again, you're going to be seeing a high rate of success with fewer complications or failures. And trying new things, there's nothing wrong with that, because we learn by trying and seeing, wow, this worked really great in that surgeon's hands. Maybe that will work really great in my hands. Mm-hmm. But then sometimes that patient maybe isn't the best example of a case where that would be successful. So you still have to pivot, I'm sure, sometimes.
Yes. Totally.
As we kind of wrap this up, before we do a question that you'll leave for my next guest, if I were a technician working in a general practice or a veterinary student or a veterinarian in a general practice setting, what would you think would be the most important thing they should remember from this episode, especially when it comes to seeing these young animals in their practice?
What's the most important thing? I think the quality of life of the animal has always got to be our top priority across the board. All of the things that we talked about may not apply in every case, but the earlier we know what this pet is up against and what resources we can offer, I think we can all help the client make an informed decision about how we can best support them in their decisions, whatever those are. I mean, that starts with every single person that's involved, from the customer service representative at the front desk answering questions. I mean, that my front desk staff are trained about people that call about these kinds of puppies and what the next steps are there. I think just having those scripts and conversations with your staff is important, because obviously veterinary students will not have seen very many of these cases, but same thing with the technicians, they may not have seen very many of these cases. I don't know, it seems like a no-brainer to say quality of life, but I think that's my answer.
We're patient advocates.
Yes.
And first of all, before a problem can be addressed, we need to recognize there's a problem. And understanding how every single person on our team is really instrumental in making sure that the patient advocacy happens and that the client communication happens effectively, so they know what's the next steps, what should we be thinking about, what should we be doing, and that this is a real problem in a percentage of these puppies and kittens out there, and that there is something maybe we could do to help them, and then they have a great quality of life once we get them through the formative year there, where they're dealing with a lot of stuff and maybe some additional surgery that most pet owners don't plan on. But
sure. I mean, I do think that's, as I said, there's a lot of effort that goes in amongst everybody, and that can be a lot. And I think that's why there are some breeders that would say there's just no chance for this dog or cat. But these animals can live a really good quality of life. They really can, especially if it is some of the more, again, you just don't know in those early days what may end up being. And I do love following some of the social media accounts of some of these dogs, because I think, for example, Lentil, who John Lewis worked on, and I'm not sure if that dog is still alive, but that person has adopted more dogs like that, and she's become a big advocate for supporting children going through those types of cleft surgeries. So like they travel around with these dogs that kind of have the same thing that they're going through, and it just makes, it's just that, again, one health human animal bond that
when I watch stuff like that, it always makes me cry.
I know.
Because these little children that feel so ostracized because they have these things, if they saw another animal that's like them, it just makes them feel like they're not alone. And oh gosh, that definitely the human animal bond and children and pets, and it's just so heartwarming to know that these animals not only we're trying to impact their life and make their life better, but really they impact us more than we impact them.
Wait, for sure. Yeah.
Before we cry.
I know. I was like a little bit like,
I know. We're going to get teared up here, but it's so great. This has been an awesome topic, and I just so appreciate you being here with me today to bring this information. And honestly, I feel like it just speaks to the fact that we need to learn more about this stuff, and there's so much to learn, and we can't possibly do it in a podcast episode, but I will link in the show notes anything that you think would be really helpful for the listeners.
Sure.
Any publications or articles, or even that Facebook page where people can go if they are trying to raise up one of these puppies or kittens and get it to a healthy enough state and an age which veterinary surgeons such as yourself could address the cleft palate or the cleft lip or other deformities that have to do with oral maxillofacial surgery. So as we wrap up, you get to leave a question for our next guest. And I can't tell you who my next guest is going to be, but this question is going to be for someone who is a veterinary dentist or a veterinary technician specialist like myself. So they probably know a lot about dentistry, but it can be anything. Like you said, you wanted to know what animal or patient was really memorable or your favorite. So so what do you think?
I guess, I don't know if maybe this question's been asked before. It might be simple, but I'm always curious to know, what is your, I guess in the case of a dentist, what is your favorite procedure to do? Are you a root canal person? I'm not. I'll be honest. I don't like the root canals. But I know Chris Bannon loves a root canal. It always fascinates me to know what really gets you excited when you see it on your schedule. Same with the technicians. Is there something that you really love to assist in, or just a part of your day that you just find to be like validating for what your career path is?
Okay, that's great. I love those questions. That's really important because I feel like we often don't get a chance to get to know each other well. We're all doing our dentistry out in the world, but I love this question thing because I feel like we're also getting to know each other better through this podcast. So
yeah, absolutely.
Perfect. Thank you for that.
Absolutely.
So Dr. Taney, thank you so much for sharing your expertise today. This is one of those topics where early recognition and proper management truly make all the difference. And to our listeners, this is your reminder that even routine exams can reveal life-altering conditions when we take the time to look closely. So if you found this episode valuable, please follow, share. I also have a YouTube channel, so if you're listening to the podcast today, you can actually watch this on my YouTube channel. Positive Dental Education is my business. PositiveDental.com is my website, and keep doing positive dentistry. I will see you next time at the next episode.